A 30-year-old male presents with severe hip pain and limitation of movement. I am showing you the pelvic radiograph. Describe the findings.
Right, so the pelvic radiograph demonstrates marked irregularity, sclerosis, and loss of height of the femoral head, consistent with advanced avascular necrosis. The acetabular roof and joint space remain relatively preserved, with no significant secondary degenerative changes yet. Crucially, there is bilateral sacroiliac joint fusion, indicating a background seronegative spondyloarthropathy. Given this background arthropathy, the avascular necrosis is highly likely drug-induced, secondary to long-term systemic corticosteroid therapy used to treat the inflammatory condition.
What is the differential diagnosis for avascular necrosis, and how can we search for clues to the underlying cause on radiographs?
The differential diagnosis for avascular necrosis can be remembered by the mnemonic dried hip, representing diabetes, radiotherapy, inflammatory disorders, endocrine causes, drugs like steroids or alcohol, hematological conditions such as sickle cell disease, infection, and injury. On pelvic or abdominal radiographs, we look for ancillary clues. H-shaped vertebrae, gallstones, or splenic calcification suggest sickle cell disease. Sacroiliitis, a stoma bag, or colonic thumbprinting suggests steroid therapy for seronegative arthropathy or inflammatory bowel disease. A pelvic transplant kidney suggests immunosuppressive steroid use, and vascular calcification points to diabetes.
I am showing you radiographs of a child's pelvis. Describe the findings and explain their significance.
The anteroposterior pelvic radiograph of the child demonstrates a subtle, subchondral radiolucent line parallel to the articular surface of the femoral head, which represents the crescent sign of early avascular necrosis. The corresponding frog leg lateral radiograph demonstrates this subchondral crescent sign much more clearly, showing early subchondral fracture and impending femoral head collapse. This patient was a child undergoing steroid therapy for leukemia, demonstrating that early avascular necrosis can be difficult to detect on standard views, but is often highlighted on frog lateral projections.
Discuss the pathophysiological stages of avascular necrosis and the radiographic progression.
Avascular necrosis results from interruption of the microvascular blood supply to the bone, causing osteocyte and marrow necrosis. The earliest radiographic sign is relative sclerosis, where the dead bone appears hyperdense compared to the surrounding viable bone undergoing osteoclastic resorption. This is followed by a subchondral fracture, visualized as the radiolucent crescent sign. Progressive collapse, fragmentation, and flattening of the femoral head then ensue. Eventually, the incongruous articular surfaces lead to joint space narrowing, osteophytes, and severe secondary osteoarthritis.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these radiographs with prior studies to evaluate the rate of femoral head collapse and sacroiliac fusion. I would recommend a dedicated MRI of both hips, which is the most sensitive modality to detect early avascular necrosis in the contralateral hip and assess the extent of necrosis. I would promptly communicate the findings of avascular necrosis and sacroiliac fusion to the referring rheumatology and orthopedics teams. Finally, I would suggest advising the patient on protected weight bearing and referring for joint preservation or eventual total hip arthroplasty.